Let's go over the warm-up review. First question, what histological findings of the distal duodenum are most likely seen in a patient with celiac sprue? So you're going to see blunting of the villi and hyperplastic crypts. And there will usually be lymphocytes in the lamina propria. Next, what are the branches of the celiac trunk? So the three branches that directly come off the celiac trunk are the left gastric artery, the splenic artery, and the common hepatic artery. And then the common hepatic artery gives off the gastroduodenal artery, the right gastric artery, and the proper hepatic arteries, which divides into the right hepatic artery and the left hepatic artery. The last one. A woman with a history of hypertension presents with sudden onset of sharp, tearing chest pain that radiates to the back. What's the most likely diagnosis, and what would be seen on a chest x-ray? So this is a classic description of an aortic dissection, and the classic chest x-ray finding would be widening of the mediastinum. So now we're ready for the lecture.
Welcome back. We're going to continue talking about evidence-based medicine and how we apply the results of our studies and testing in a practical way. I'm going to assume that you're watching these videos in order, and you've already seen the lectures on research study design and evaluation of diagnostic tests, because this lecture is going to build upon some of the concepts we covered there. One thing we touched on briefly in that video was the concept of disease prevalence and disease incidence. But let's define these terms in a little more precisely. This is pretty easy to understand, and it's also very high yield for your test. Let's start with prevalence, since we were just talking about how prevalence changes the positive and the negative predictive value of a test. What is prevalence? Prevalence is calculated by putting the total number of people in the population that have a certain disease in the numerator and putting the total population in the denominator. This gives you the proportion of the population with a certain disease at a given point in time. That is point prevalence. Say we are looking at the prevalence of COPD. We don't really care if the person has a newly diagnosed COPD or if they've had the disease for 15 years. All we care about is how many people in the population have COPD, period. But that is not true for incidence. Incidence only concerns itself with new cases in the population. So, to calculate incidence, you take the total number of new cases diagnosed over a given period of time, and you divide it by the total number of individuals at risk for the illness during that time period. So, incidence is concerned with the new cases, and prevalence is concerned with the total ongoing cases, old or new. With this in mind, you can see that some diseases will have a greater incidence than prevalence, and some will have a greater prevalence than incidence. Take COPD, for example. Only a few people are diagnosed with COPD on any given day. But when they are diagnosed, that diagnosis stays with them for the rest of their life. So the incidence may be low, but because it's a chronic disease, the cases just continue to build up. And this yields a high prevalence. What about an acute gastroenteritis, though? That's like your 24-hour stomach bug. That may only last a day or so, but can occur several times a year. So at any given point in time, there will be a lot of people with gastroenteritis, which means there's a high prevalence. But because people may get it more than once per year, you can see how the incidence, or the new cases within the given period of time, could really be high too. So one way to think about this relationship is that prevalence roughly equals the incidence multiplied by the disease duration. And because with chronic diseases and the disease course is very long, the prevalence of a chronic disease is greater than the incidence. For acute diseases, like the common cold or the stomach bug, the prevalence will roughly equal the incidence. One important thing to remember is that the incidence is the number of cases over a given period of time divided by the total population at risk. So when you're talking about COPD or some other disease, the population who already has the disease may not be in the new case, so they're not counted in the denominator. But they're also not at risk anymore because they already have the disease. So remember to correctly determine your population at risk when you're calculating your incidence. You need to really understand incidence and prevalence. This is a pretty basic concept and it is high yield, so make sure you understand the difference. Next, let's talk about the odds ratio and relative risk. This is also a 5-star topic. You're going to see questions about this. Both are going to be used to evaluate the results you get from our study. Let's start with relative risk. Remember that relative risk is calculated from cohort studies, which is where you're confirming risk factors. Relative risk is the probability of getting a disease in the exposed group compared to the probability of getting that disease in an unexposed group. Let's build another 2x2 table, just like we did for sensitivity and specificity. This is labeled slightly different. We still have disease written on the x-axis, but for the y-axis, instead of looking at a test result, we're now looking at some exposure, some risk factor. This table will help you determine the relationship between the risk factor and the disease outcome. This is another great marker board topic. It's definitely high yield for step 1, so it's important to understand these concepts and know the equations to calculate the odds ratio and the relative risk. So, what is the equation for the relative risk? It is A divided by A plus B all over C divided by C plus D. You are going horizontally here. These equations are the fundamental components of some other calculations. If you know A divided by A plus B and C divided by C plus D, we're going to use that as part of the equations for attributable risk and also odds ratio. We said that odds ratio is used for the case control studies, which are often used to identify risk factors. The equation for odds ratio is A over B divided by C over D. So, the odds ratio compares the odds that someone will develop the disease in the exposed group to the odds that someone will develop the disease in an unexposed group. A over B divided by C over D. Now, you may see this equation written a little differently in some review books, where it's written A over C divided by B over D. But don't get confused. Both of those equations are actually correct. They are actually equivalent, although it may not seem obvious. A over B divided by C over D equals A over C divided by B over D. Try plugging in some numbers or working through some algebra. Prove to yourself. I promise they're equal. But here is another important thing to know. The odds ratio approximates the relative risk of the disease prevalence is not very high. So, let's see if we can figure this out. How does the low prevalence affect A, B, C, and D? And what does that do to the relative risk calculation? If the disease prevalence is low, you're going to decrease A and C, and you'll increase B and D. Let's assume that the disease prevalence is so low that A and C become minuscule. If A and C become minuscule, how does the equation for relative risk change? Remember, the equation for relative risk was A over A plus B divided by C over C plus D. So, if A is a tiny number relative to B, and then A plus B essentially just becomes B, right? If A is 1 and B is 1,000, there's not much difference between 1 over 1,000 and 1 over 1,001. So when prevalence is low, A over A plus B essentially becomes A over B. And when C is minuscule, C over C plus D becomes C over D. So when prevalence is very low, the relative risk equation becomes A over B divided by C over D. Then look back at the equation for the odds ratio. It's the same thing, A over B divided by C over D. So if you have the equation for a relative risk memorized, and you know the odds ratio approximates relative risk when the prevalence is low, then you'll know the equation for the odds ratio. Now, let's talk about attributable risk, which is slightly different. Attributable risk is the difference between the risk of disease among the exposed and the risk of the disease among the non-exposed. So this implies that there's a risk factor that is increasing the risk of the disease. There's an example in your study guide. It says that attributable risk is the incidence of disease in the exposed group minus the incidence of the disease in the unexposed group. For example, in a group of sexually active people, 30% have an HPV infection. In a population of people who are not sexually active, only 5% have HPV infection. Therefore, the attributable risk of sexual activity to HPV is 25%. This is an example of how you would have to calculate attributable risk on step 1. It's certainly not difficult as long as you know the concepts and remember the equations. Now, let's take a second to talk about absolute risk reduction. The absolute risk reduction equation looks a lot like the equation for attributable risk, But instead of looking at how much a risk factor increases the risk for disease, we're looking at how much a beneficial intervention will decrease the risk of the disease. In other words, A over A plus B becomes the proportion of people who have a disease from amongst all of those who receive the intervention, like a study drug. C over C plus D becomes the proportion of people with a disease out of the entire population that did not receive the intervention or study drug. So the calculation for absolute risk reduction is C over C plus D minus A divided by A plus B. We want to know the difference between the risk of the disease in the control group and the risk of the disease in the experimental group. If the risk of the disease without the drug is 10%, but the risk of the disease with the drug is 5%, then the absolute risk reduction is 5%. Let's go back to the study guide to discuss the numbers needed to treat. The number needed to treat, or NNT, is 1 divided by the absolute risk reduction. If you can calculate the absolute risk reduction, you can calculate the number needed to treat. The number needed to treat is the number of patients you would need to treat in order to save 1 life or to avoid 1 bad outcome. It's the number of people you would need to treat to get the effect you want to get in at least 1 person. This can be an important number to help you determine if a drug is cost effective. If you have a drug out there that is very small effect and you need to treat 1,000 people in order to save 1 life, the drug is probably not worth widespread use. We also use this number to evaluate clinical effectiveness of a drug. There's an example in your study guide. There are 100 acute stroke patients given TPA, a clot-busting drug, and 40 of them have a complete or near complete recovery. Now, there are 400 acute stroke patients not given TPA, and 80 of them have complete or near complete recovery. First, you calculate your absolute risk reduction, which is the risk of poor outcome without the treatment minus the risk of poor outcome with the treatment. Poor outcome was experienced in 320 out of 400 in the control group who were not given TPA, which is C divided by C plus D. A poor outcome was experienced in 60 out of the 100 in the group given the TPA, which is A divided by A plus B. So the absolute risk reduction is 320 divided by 400 minus 60 divided by 100, which is 0.2. To calculate the number needed to treat, you take the inverse of absolute risk reduction. That is, you calculate 1 over the absolute risk reduction, which is 1 divided by 0.2. This equals 5. Therefore, you need to treat 5 patients with an acute stroke to see the beneficial effect of TPA in 1 patient. There's also a similar concept called the number needed to harm, which I'll just mention briefly. Like I said, attributable risk is similar to the absolute risk reduction. It is just a measurement of the extra risk that is due to an exposure rather than decrease in the risk that is due to a beneficial intervention. So, as you may expect, the number needed to harm is similar to the number needed to treat. The number needed to harm is 1 divided by the attributable risk. Go ahead and look at your study guide again. What is the absolute risk reduction and the number needed to treat in the following example? In a study where 100 patients received medication Z to prevent the development of diabetes, and 200 patients did not receive the medication. 10 patients in the experimental group developed diabetes, and 40 patients in the control group developed diabetes. I want you to pause the video and try to work that out, and don't take more than 1 or 2 minutes and we'll go over it together. So the first thing to do is set up a 2x2 table. A is 10 because 10 people received drug Z but still got diabetes. We know that A plus B is 100 because that's the total number of subjects that were given the drug. So if A plus B is 100 and A is 10, then B must be 90. C is 40 because this was the number of people in the control group who developed diabetes. And then, if the total number of subjects in the control group was 200, then D must be 160. So the equation is C divided by C plus D minus A divided by A plus B. This comes out to 40 over 200 minus 10 over 100, or 0.2 minus 0.1. So the absolute risk reduction with the study drug is 0.1, which is 10%. Then wait, what's the number needed to treat? Remember, the number needed to treat is 1 over the absolute risk reduction. Therefore, the number needed to treat in this question is 1 divided by 0.1, which is 10. Therefore, you need to treat 10 patients to prevent 1 case of diabetes. All right, this is all very high-yield stuff. Odds ratio, relative risk, attributable risk, absolute risk reduction, number needed to treat, number needed to harm, all 5-star topics. Now we're going to briefly cover precision and accuracy, also known as reliability and validity. So precision, or reliability, is the measure of how reproducible a result is. With a precise or reliable result, you get consistent results every time. So a precise test will not have a random variation and will therefore be reliable and reproducible. But the kicker is that precision does not necessarily imply that the reliable and reproducible results actually reflect the truth. That is where accuracy comes in. Accuracy, or validity, is a description of how closely the test results reflect the truth. With an accurate test, there may be variation in the results, but the variation will occur right around the true value. So you should remember the difference between reliability and validity. Validity is how accurate a test is, or how well it reflects the truth. And reliability is how reproducible the test is. Ideally, any test you would use to have the combination of precision and accuracy. All right, that's all we're going to cover in this video. So what I want you to do now is pause the video, answer the end of session quiz questions in your study guide, and then we'll go over those answers. Let's get started. What are the equations for odds ratio, relative risk, attributable risk, and number needed to treat? Odds ratio is A over B divided by C over D. Or another way to say this is A times D divided by B times C. This is the odds of having a particular disease in a group with risk factors divided by the odds of a particular disease without having the risk factors. Relative risk is A over A plus B divided by C over C plus D. This is the probability of acquiring a particular disease in a group with risk factors or exposures, compared to a group without the risk factor or exposures. Attributable risk is the risk of developing a disease in a group with the risk factors minus the risk in the group without the risk factors. Or A over A plus B minus C over C plus D. And the number needed to treat is just 1 divided by the absolute risk reduction. And just like the last video, there aren't any rapid-fire facts, but make sure you know these equations, and also the absolute risk reduction. Next, a small town of Breathless, population 8,000, is immediately adjacent to factories where asbestos products were produced. During the past year, the prevalence of mesothelioma has been 16 cases. The town of Clear Air, population 6,000, 15 miles upwind, and theoretically a safe distance from Breathless, there's a prevalence of 3 cases during that same year. So what's the relative risk of mesothelioma for the population of Breathless? The first thing you do is set up your table like this. The number of people with the disease in Breathless is 16, and the number of people with the disease in Clear Air is 3. The question didn't give you the number of people without the disease, but you don't really need it. All you need to know is A plus B and C plus D, since the equation for relative risk is A plus B divided by C over C plus D. So, 16 over 8,000 divided by 3 over 6,000, and that gives you 4. So the relative risk is 4. This risk of mesothelioma is 4 times higher in Breathless than it is in Clear Air. Next, a new glucose test arrives, and you decide to see how well it works. There's a standard substance provided that has 90 milligrams per deciliter of glucose. Your repeated measurements of the substance reveal the following values: 54, 56, 55, 54, 53, 56, 55, and 54. What can you say about the precision and accuracy of your new glucose test? You would say that this test is very precise since the results are all staying within a very narrow range of numbers. The results are very reproducible. But this is not accurate. The results aren't anywhere near what the true value is, which is 90. Last question. The prevalence of disease X in population A is 2 times the prevalence of disease X in population B. The incidence is the same in populations A and B. What can be assumed about the disease duration in population A versus population B? If the incidence is the same in both populations, but the prevalence is different, you have to assume the disease lasts longer in one population than in the other. So in this example, the duration of disease X is twice as long in population A as in population B. That's the end of session quiz, and that's the end of your lecture on application of test data. We'll see you next time.